trying to decide how to treat a patient with relapse, first question is, where is this patient on that continuum of purely biochemical relapse to fulminant disease? And not everybody with a mild biochemical relapse, which isn't even fully detectable by or fully measurable by IMWG criteria, that patient potentially could be watched for a few months longer until we do have symptoms. Conversely, if that patient has symptomatic disease, we need to obviously start therapy immediately, regardless of whether or not it's measurable. And it's important to know that some patients who have initially a heavy chain component, say they have an IgG kappa M spike of 1.3 at the time of initial diagnosis, by the time they relapse, they may have that concept of free light chain escape. They only have kappa light chain. So it's important that community doctors check all of those myeloma labs in maintenance patients so that we're not missing that type of relapse. And so if somebody had this symptomatic relapse, as our patient does have, then I think the first question is, what kind of regimen do we use? And to answer that, fortunately in myeloma, we've had a plethora of relapse studies. In fact, 7 phase 3 studies and 1 randomized phase 2. And it's unprecedented, I think, in oncology to have so many studies to choose from, all phase 3, all randomized, all high quality studies that have all led to approval of these agents. So the first thing that I think that we need to do is break these studies down into either a len-based backbone or bortezomib-based backbone. And that's important because this patient, for example, is on lenalidomide maintenance. By definition, her progressing on len maintenance would make her ineligible for all 4 studies that required len sensitivity, because there was a control arm in those 4 studies where half the patients were only getting len dex, and that might not be appropriate if somebody's clinically relapsing to just give them a little bit more len and dex. We do that sometimes outside of studies, because if it's a biochemical relapse, perhaps we could milk some more mileage, but in a prospective clinical trial, that would not be appropriate, especially when you have a randomization regimen there that we need, depending on the outcomes of both arms, to be as good as possible. So this patient, if we were practicing evidence-based medicine, we couldn't use those 4 studies. So we would then go to the PI backbone studies, and for those, we have pretty much for all of these studies, we have a DARA-containing regimen, a carfilzomib-containing regimen, an ELO-containing regimen, and in this study, there's also, in the PI studies, there's also a panobinostat. So to summarize, we have DARA VD versus VD, KD, which is high-dose carfilzomib at 56 milligrams per meter squared versus VD. We have the elotuzumab VD versus VD, although this is a randomized phase 2, but also sizable 150 patients or so. And then lastly, we have the panobinostat, pano-VD versus VD. So we have 4 studies, and it's important to remember that as we were taught in medical school, it's always tempting to compare across studies. Let's just take the one with the best response rate, with the best PFS and the best OS, and then boom, apply that to everybody. But the problem with that is these studies are not balanced, and there's always going to be differences between the eligibility criteria. Were they relapsed at the time of entry? Were they actually refractory? How old were these patients? What is their risk status, both international stage and molecular risk? How many lines of prior therapy did they have? Were they being enrolled in ex-US or US, where the initial therapies may have been very different? And I bring up all of those factors because we really can't compare directly the median PFS, for example, across all these studies. And although it's intellectually the most easy to do, it's also intellectually the laziest to do. And what we really need to do is look at hazard ratios, which at least gives you the relative value added within each study for the novel agent versus conventional. And what's interesting is when you look at these hazard ratios for all of these studies, pretty much they all line up in this 0.6 to 0.7 range, with one exception, and that's DARA. DARA-RD or DARA-VD. In this case, DARA-VD relative to, this is the Castor study, DARA-VD versus VD, the hazard ratio was quite impressive, 0.39, or the other way of saying that is 61% reduction in the risk of progression or death. So that's quite impressive, and admittedly, the follow-up is not going to be as long as those other studies, so we don't yet see OS benefit, but that's going to require a longer follow-up. But I think it's for that reason that people are so interested in DARA-containing regimens, that these hazard ratios are quite impressive. Again, it's not to say that those other regimens will not be appropriate, and they're all excellent regimens. They all will work very well. But if you had to pick what would be the best option in terms of evidence-based, that's probably one of the most compelling. And so that would be the approach for this patient, given that she was a len maintenance failure. Now, it's also important to talk about the other options, because there are another group of 4 studies that are equally compelling that have len-based backbone. So again, we have a DARA-RD versus RD. This is the POLLUX study. We have carfilzomib-RD versus RD, which is the ASPIRE study. We have ELO-RD versus RD, which is ELOQUENT. And then the last study is ixazomib-RD versus RD. So we have now 4 more regimens that are len-containing, and how do we pick? Again, the same caveats apply. There's differences in patient populations, and it's easy to just say, okay, I'm going to take the one with the highest PFS, but that's, again, not the right way to do it. And if we look at the hazard ratios, yet again, they kind of stack up in this 0.5 to 0.7 range, with the notable exception of POLLUX, where DARA-RD versus RD gives you a hazard ratio, again, in the 0.3 range, again, showing a much better reduction in the risk of progression or death. So it's a very good regimen to consider for patients who are progressing. And so this patient obviously would, and this is where that generalizability of a study to the patient is so important. The hazard ratios that we just talked about for the len-containing regimens may not be applicable to this patient because she's len maintenance failure. So if we were to try to add the third drug to her len-dex, we may not be able to guarantee that the benefit for her would be as good as it was for the other patients in that study, who by definition could not be len refractory, including could not be refractory to len maintenance. So it's nice that for DARA and for carfilzomib, there are both regimens containing PI backbone as well as an IMiD backbone. And so I think it's nice to have all of these options. And at the end of the day, the choice of a regimen is really going to be patient-specific as well. We need to think about this patient's age, frailty, comorbidities, neuropathy rates, renal function, and those are host factors. The second thing to consider is the disease factors, which is not only the burden of the disease and symptoms, but also the biology. Is there a molecular risk? And lastly, we need to think about therapies. And the therapies include, meaning what have they had before? How well did they respond? What toxicities did they have? Is this therapy going to be parenteral or oral? Is it going to be combination or single agent? What is the cost of this drug, both to the healthcare system, but also to the patient in terms of out-of-pocket costs? So I think we have a lot of factors to consider, and at the end of the day, this is why we say medicine is an art, not a science, because you can have all of these evidence-based studies with hazard ratios, but maybe you have to throw all that out the door when you see this patient in front of you where it doesn't apply. And so I think it's nice to have evidence, though, to have so many choices that you can pick the right combination for the right patient.